From the JAMA Network, this is JAMA Pediatrics Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Pediatrics.
Hello again, this is Dimitri Christakis, Editor-in-Chief of JAMA Pediatrics. With me again, as always, is one of my associate editors, close friend and colleague, Dr. Alison Galbraith. Hi, Allie. How are you?
Hi. Good, thanks.
And today, this is, I think, our fourth episode in our new format, and I hope that you're enjoying it. Please feel free to give us feedback. In this format, we use a couple of articles recently published in JAMA Pediatrics as our launch point to engage a national, even an international expert in important topics in pediatrics. And today is no exception. Joining us today is Dr. Grace Lee. Dr. Lee is the Chief Quality Officer and the Christopher G. Dawes Endowed Directorship in Quality at Stanford Medicine Children's Hospital. She has many other titles. She's also served as a member of the ACIP and is the now past chair of the ACIP. But as she will point out, she is not here representing the ACIP. It's just a testament to what an expert she is in infectious disease and immunizations. Hi, Grace. Thanks for joining us.
Thanks for having me, Dimitri and Alison. It's great to be on.
Great to have you.
Yeah, it's great to have you. It's great to see you virtually. I've missed you. I haven't seen you in a while. Okay, Allie, why don't you set us up with the articles that made us think of Dr. Lee, and let's get started.
Yeah, so we have two papers. These were both published in October, and they are both about COVID vaccination, but from two different perspectives. So the first is newborn and early infant outcomes following maternal COVID-19 vaccination during pregnancy from Jorgensen et al. And in this, they wanted to test if maternal COVID vaccination during pregnancy was associated with adverse infant events. So they did a population-based propensity-matched cohort of over 140,000 births in Ontario with administrative data. And they found, reassuringly, that infants of vaccinated mothers had lower risk of severe neonatal morbidity, death, and NICU admission, and no associations with neonatal readmission or 6-month hospitalization. So that was reassuring because they set out to test safety of vaccination in pregnant people for infants. The second paper is about children, the effectiveness of monovalent mRNA vaccine against Omicron XBB infection in Singaporean children younger than 5 years from Wee et al. And in this paper, they wanted to test the effectiveness of the monovalent mRNA COVID-19 vaccine against COVID infection among children aged 1 to 4 during an Omicron wave, which was October 2022 to March 2023. So this was a population-based cohort. Also, this was in Singapore, more than 121,000 children. And they found that the vaccine effectiveness against infection was 45% in partially vaccinated infection-naive children versus unvaccinated, and 63% in fully vaccinated infection-naive children. And that they found that hospitalization due to COVID was rare overall in general and zero among those fully vaccinated. So those are the two papers. And I guess, Grace, one of my questions for you to start off is, we have a paper about vaccination and pregnancy, and we have a paper about vaccination of children. And I know you think about both patient care and policy, clearly, in the ACIP. And when we're making these decisions about vaccinating individuals, how much do we also think about considering vaccination for the parent or other household members? And, how does the ACIP think about that?
Well, thank you for the question. And I'll just state that I am only representing my own opinions, although I've had the pleasure and the honor of serving on ACIP since 2016 and during a period of a lot of activity. I'll just share.
Yeah.
These are just my opinions. So it's an interesting question you raise around cocooning. It's certainly a strategy that we've used with Tdap vaccine, and we've talked about how do we protect the neonate who's not able to receive a full series of pertussis vaccines and be fully protected until they're at least 6 months of age. And so, as you know, one of the opportunities we use is vaccinating women during their pregnancy in order to enable those antibodies to cross the placenta to be able to protect that neonate during their most vulnerable period. For those who are clinicians on the call, you'll know that neonatal pertussis actually can be frightening in that it's not necessarily presenting with a cough, but really just with sudden apnea. And so to be able to prevent something like that by providing protection to the mom, not only protecting that mom against tetanus and diphtheria, but also providing that extra boost against pertussis, but especially as a way to get antibody to the infant, as well as protect that mom. Tdap has been used also, as you mentioned, around vaccinating other household members like grandparents who may be susceptible as a way to protect that infant.
Right.
We have not discussed that in this case yet. I would say that there's been a lot of really interesting developments now with vaccines during pregnancy, specifically with COVID vaccines now available. We've had flu vaccine for a long time, Tdap vaccine for a while, and now RSV vaccine.
Right. There's a lot of parallels, right, with RSV.
Yeah.
And it's interesting. We're talking about not only protecting the mom, for example, with COVID vaccines. We know that COVID infection during pregnancy leads to more severe outcomes for that pregnant person. So not only are we able to protect that pregnant person, but we're able to protect their infant potentially. And I think this is focused on safety in particular. But I also think that there's been really promising data to suggest that we are also providing that protection to the infant, transplacental transfer of antibodies. So that's one example. RSV specifically, we're really intending to protect that infant during that most critical period when we know kids get RSV and are likely to be hospitalized. So long story short, I think that is a future direction that we could potentially talk about. And I think we now have these innovative products available to us to be able to explore this. And I certainly think that, I'm really appreciative of our OB community who's done a phenomenal job really ensuring that pregnant people have access to these vaccines, which is so important.
Thanks, Grace. You mentioned that you've been serving in this capacity during interesting times, as they say. I'm curious what you think about a topic I'm sure you've talked about quite a bit, namely vaccine hesitancy, and how COVID has impacted that positively or negatively. The data Ali mentioned pointed to both safety and efficacy of the COVID vaccine, and yet, as you know, uptake of that vaccine remains low and going down as we go forward. And to some extent, it seems like there's been some level of contagion, for lack of a better word, that this has brought all vaccines back into question. I'm curious what you think about that, and both as a policy expert and as a clinician who's advising parents, in this case, either mothers for themselves or mothers for their children.
Yes, vaccine hesitancy has been a very challenging topic. It's a dynamic one too, right? So early in the pandemic, we were so fortunate to have something called Operation Warp Speed that was able to get a vaccine to market, in a matter of 9 months, which was phenomenal. It was miraculous. I mean, we did not think we would be able to provide a vaccine to the public by December of 2020. That in and of itself was amazing. I think people got caught up with the name and decided it was too fast. But we were seeing lots of children early in the pandemic who were really sick from COVID infection. And the idea of being able to prevent such an infection through having a vaccine product available was at that time nothing short of a miracle, to be honest. So during that time, the FDA and the CDC and the manufacturers and NIH, all did a Herculean job just trying to be able to get a product to market to have that available. And you'll remember how much demand there was for it at that time, especially amongst the older adult population, those who are immunocompromised, and our healthcare personnel. And we also, as a committee, felt very strongly about wanting to ensure we were protecting our frontline essential workers, many of whom had to come in and serve in their roles in order to keep society functioning. So there was huge demand and a huge need for it. I think over time, as vaccine became more accessible, we started to hear questions about, was it too fast? And I will say that I think that in order to be able to respond to the public health emergency, everything was about benefit risk balance. And I have to say, those were some of the largest trials we had seen stood up in the shortest amount of time with an incredibly diverse population, and more diverse than I had seen in the past 5 years in most of our clinical trials, to be able to ask and answer that question. And it was amazing. I mean, to be able to look at the effectiveness estimates at that time. Now, we've learned a lot since then. So I think that some of the challenges have been how to address people who were concerned that the product came to market too quickly. There were unbelievable efforts that were made to stand up real-time safety surveillance systems. And in fact, related to this article, you'll remember that there was something called VSafe, where it was volunteer reporting so that people who received the vaccine could share any symptoms they were having, any potential adverse events. And at the time, I remember we were thinking, gosh, we don't know how many pregnant people are going to want this vaccine. And we were shocked because you'll recall early in the pandemic, when there weren't enough doses, the healthcare workforce was prioritized. In short order, we had over 20,000 pregnant women who volunteered to share their information with the CDC regarding the safety of the vaccine. And they were all recipients of the COVID-19 vaccine in that first wave. And so first, we were just shocked, number one, that there were that many pregnant people who wanted to get the vaccine. And second, we were so amazed at the data from that and from VSafe because it was really reassuring to see that there were no adverse effects that we could tell from the VSafe system. It has its limitations, but we were also looking into other vaccine data safety surveillance systems with the CDC and the FDA. The DoD was supporting the VA, CMS. I mean, it was all hands on deck monitoring the vaccine safety in the overall population and in pregnant people as well as in young children. And it has been a reassuring story. So to get back to the hesitancy question, I think it's changed over time. So in the beginning, I feel like we didn't see that much hesitancy. We saw sort of a huge need for it, a huge demand for it. Over time, as it became rolled out to the broader population, I think the role of social media in sort of vaccine acceptance has been huge. The last time we had the closest thing to a pandemic would have been H1N1, and you'll recall that there wasn't much social media at that time. So a very small minority of voices could create a huge degree of uncertainty and fear, despite all the robust data presented. And so I think it is our new reality, and we're going to have to learn and live with that. To be able to communicate effectively, I think, as you can tell from my very long-winded answers, that science is complicated. We want to give a really thorough discussion around all of the issues. But at the end of the day, it really comes down to a short tweet about whether or not you're going to believe whether or not a vaccine is safe or effective. So when people come to me and they ask what they should do for their children, and this literally happens, I do the best thing I can say in a very short email or a text usually is when people are asking me, I'm about to take my child to the doctor. Do you think it's a good idea? And I respond back with, I think it's a great idea. I vaccinated my own kids. And I feel it's really important for me to be able to protect my kids the best way I can. We know that not only is it going to help in the short term, and believe me, my kids did not like missing school for the entirety of the pandemic. And they still actually are scarred from that and do not like to miss school. So they don't want to miss school for being COVID positive. Even if they're feeling well, they're not hospitalized. They don't want to miss the ability to be able to attend school or miss their classes and then get behind. I also highlight, and there's been some good data to show that post-COVID conditions, long-term consequences of COVID infection actually are real, more frequent in the adult population than the pediatric population. But at a time where we really are worried about the neurodevelopmental outcomes of our young kids, I think it's a really important aspect of prevention that we don't talk about very much. We're so focused on that acute infection, we're not really talking about the long-term benefits of protecting them or giving them at least a leg up in terms of immunity.
That just made me think of in the paper about the children. It was effective against infection and it was very effective against hospitalization, but the hospitalizations were so rare. And if we're thinking about vaccinating children compared to vaccinating pregnant people or older adults, on the one hand, it seems like if we vaccinate children and they don't get infected, then they're not going to spread it to older people who will be in the hospital, or do we try to have a strategy to try to get more of the people who will get really sick vaccinated?
Yeah, so one of the challenging things, both with COVID and flu, is that it's all your frame of reference. There are approximately 80 to 100 deaths due to influenza infection each year, and similar for COVID infection in those under the age of 18. So while not at the same magnitude as our older adult population, those are really preventable deaths. And if you look into the characteristics of those individuals who had really severe infection, 50% basically have no underlying medical conditions. So if there was an easy way for us to be able to identify people who are going to be at risk for severe complications, it would be easier to say, these individuals with these conditions should absolutely get vaccinated. When you know that half of the kids who are hospitalized under the age of 18 don't have any comorbid conditions, it's really hard to predict who's going to be hospitalized or who's going to have a complication of COVID that results in a rare death. But still, I think the one way to frame it is to say, if we think about it in terms of vaccine preventable diseases, COVID is amongst the most common vaccine preventable disease we have now, to be able to prevent any severe complications in those who are most vulnerable. And with hybrid immunity, I think we have a different level of immunity, both as individuals and as a population, than we did when COVID-19 first arrived in March, or some might say earlier, of 2020. So I do think we're in a different place than we were then. But the ones who are most vulnerable are those neonates who are born every year. So there's still a huge proportion.
Let me pick up on that. I mean, the most powerful tool we have, both as pediatricians and as a society, to get kids vaccinated is school mandates, which is to say to require it for schools. I'm asking you now not as a CIP. Let me just be very clear about that. It's an interesting challenge that doesn't actually fit neatly with our normal sense of red and blue or the political spectrum. Some of the strongest school mandates are in some of the reddest states in the United States. They have some of the best immunization rates for children in the country. We've not typically required influenza vaccine, and to my knowledge, almost no school district requires COVID at present. What are your thoughts on that? Should we be adding these? Why don't we? What is holding us back? For those of you who are listening and you can't see, Grace is both smiling and wincing. Yeah. So that's that. Just to know, before she answers the question, I don't know whether she's amused or bemused, but go ahead, Grace.
I was thinking, Dimitri, oh boy. Okay. Well, a couple things. So one is, while these vaccines, COVID and flu, are a wonderful addition to our armamentarium to be able to protect children, adults, immunocompromised individuals, pregnant people, etc. One of the challenges is that I don't believe there's enough evidence to show that these vaccines prevent transmission. So I certainly think that this article is promising, and it definitely protects against severe disease. That we know. It'll protect those who are infected against, it's very effective against hospitalizations, against death, against long COVID. It's MIS-C for the teens, for those who will remember in the beginning of the pandemic, et cetera. However, I think that we're going to continue to need to innovate in relation to new vaccine products, to really think about how we can develop vaccines that could impact transmission. And that's so important because you'll recall how we used to have PPSV23, so the polysaccharide pneumococcal vaccines, really good at protecting against severe disease for those who are at risk. But the conjugate vaccines were transformative. We saw that when we had PCV7 that first came out. I want to say it was 2000, Dimitri. I could be wrong about that, but that was the first time. Not only did it protect those children and create a level of herd immunity in kids, but it really protected our older adult population. So the grandparents who were susceptible to pneumococcal disease. That's the kind of vaccine that we need.
And just so I understand you, Grace, and what you're then saying or implying, I want us to all understand, is that you think that it's the infectivity or the protection against infectivity that should drive school mandates as opposed to herd immunity or individual protection. I'm putting words in your mouth, but I'm just curious if that's where you're going.
I would say there's a clearest case for when something like measles, which is highly transmissible, to ensure that we are protecting kids while they're in the school setting. And although the vast majority of children can be vaccinated, we know that there are children who are immunocompromised, and being able to be educated and have access to an appropriate educational setting is critical. And to be able to protect those children in that school setting, I think, is important. I'll also just say the same for if we think about nursing home settings where we have a lot of older, frail adults, where it's really important in that setting to make sure that we're offering those protections, or healthcare settings as another area of opportunity. And I do think that it's a clearer cut case when you can interrupt transmission so effectively with a vaccine. I think these vaccines are incredible at preventing severe disease, as we said, but it's really individual level protection. This article is very intriguing in terms of infectivity, but it doesn't really speak to transmission per se.
Oh, so you're saying, and we don't know that about flu either then?
It really is protecting us against severe disease. And so, yes, but by interrupting the risk of severe infection and even maybe moderating the duration of the infection or the severity of the infection, even if it's an outpatient infection, that all in and of itself can reduce the risk of transmission to the next person. So I do believe it is helpful, but it's not the same as what we've seen with the conjugate pneumococcal vaccines, where it's really interrupted nasopharyngeal colonization and impacted herd immunity at a very different magnitude.
Very interesting. Thank you for sharing that.
Right. Which makes sense, right? To be able to argue that you should do it in schools, it would have to be a public health message. You can't It's not an individual decision.
Yeah, and I will say that ACIP does not do any mandates. We make recommendations, but I would say that I do feel strongly that the recommendation is sound, and it's an important thing to do to protect our pediatric populations.
Great. Thank you again for listening. And thank you so much, Grace, for sharing your wisdom and your grace, I might add, with us during this podcast. It was really a pleasure to learn from you. And thank you for all that you've done to promote our understanding of infectious diseases and immunizations.
Yes, we were in good hands with Grace in the pandemic.
Thank you for having me. I appreciate you both.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.